بسم الله الرحمن الرحيم. نتكلم اليوم يا جماعة عن newer anti-anginal agents. Generally speaking, those agents has been developed after 2000, meaning has been registered to FDA, the American FDA and the European FDA by 2006, something around that. We're talking about 4 drugs, generally speaking. 3 of them is important. One of them is we just gonna touch a small story about it. It's not really in much of use. However, the 3 drugs, they have a real application within the angina. Some of these drugs will be used also in heart failure and also as antiarrhythmic agents. So let's talking about the first drug. Is the Ivabradine, and Ivabradine is a selectively inhibitor for the what we call it the IF current, which is an important current involved in generation the early phase of spontaneous diastolic depolarization in sinoatrial cells, reducing the frequency of action potential initiation and lowering the heart rate. Simply, we're closing the ion channel, the sodium channel, and that sodium channel gonna produce a reduction in the heart rate. So our target is the SA node now, and when we talk about the SA node, we're really talking about the chronotropic activity of the heart. So what we really want to produce when we use the Ivabradine is reducing the heart rate, and that what we want to have. So it decreases, I'm reading the second paragraph, it decreases the body demand for myocardial oxygen, which is we need in the angina. So remember, we're treating the angina pectoris, the demand of oxygen is more than the supply. So we want to reduce the demand, and Ivabradine doing this without any effect on blood pressure. We're not producing any reduction of blood pressure or increasing blood pressure, or we have no activity toward the myocardial contractibility or conduction time, and result in a reduction of angina symptoms. Ivabradine has a drug-drug interaction, and that drug-drug interaction generally come from that Ivabradine is metabolized by CYP3A4, and any drug that inhibit or induce the CYP3A4 will have an activity, will have a effect on Ivabradine kinetics. So if you have an inhibitor for CYP3A4, you will have an increased Ivabradine level, and if you have an inducer for CYP3A4 like rifampicin, you will have a reduction in Ivabradine. So watch for that if you're using the antifungal ketoconazole or these antifungals that inhibit CYP3A4, that will elevate the Ivabradine level. While if you're using the Ivabradine, if you're using CYP3A4 inhibitors, you will inducers, like rifampicin, you will reduce the activity of Ivabradine. Generally speaking, Ivabradine if it's have an effect, is SA node is a profound effect, so it has an interaction. It can be used with the beta blocker, however, it's really contraindicated with verapamil and dendiazine. Okay, it has a nice usage in heart failure, especially when the ejection fraction less than 35, and we'll talk about that in seconds. Now, what we have here, we have the sodium potassium pump, and it's called IF. An IF current, I'm reading now, is an onward sodium activity, and what Ivabradine do, it inhibit that current. So Ivabradine let's say inhibit the sodium potassium current, and that will, let's say, selectively block the IF, Ivabradine IF, in the current dependent fashion, reduce the slope of depolarization and slowing the heart rate. So generally speaking, what we really have an activity, we really reducing the frequency of SA node activity. So we're blocking the current, and that blocking, if you see here, we have this red and green lines, and the red without Ivabradine, while the green with the Ivabradine. So we're reducing the slope of the currents, and generally speaking, we're slowing down. If you see, we're slowing down the SA node activity. So generally speaking, we don't have to make it really complicated, but what we want to say that ivabradine is an SA node inhibitor as a pacemaker generator. As SA node, we inhibited through ivabradine by blocking activity on the sodium influx, and that's a very important issue to understand about ivabradine. The application is good enough for to reduce the oxygen demand, as we said, toward the heart, and that will, generally speaking, reducing the heart rate. And reducing the heart rate generally is our target in angina, without having activity on the let's say the inotropic activity. So this is another story. We can add it toward the beta blockers. However, it's contraindicated to be used with the verapamil or diltiazem as a calcium channel blocker, cardioselective toward calcium. Now its use. Now talk about use with beta blocker, as we said, in people with heart failure also. With left ventricular ejection fraction lower than 35, if your left ventricular ejection fraction, and we talked about heart failure yesterday, so left ventricular ejection fraction, if it's less than 35%, now we can use it, we can add it to the low dose of beta blocker that we talk about. However, there's a limitation for that. Your patient has to have 70 beats per minute as a limit, so not to get toward the bradycardia, and this is a limiting factor to be used, to be added toward the beta blocker if in left ventricular ejection fraction less than 35%. Also, in people not sufficiently managed with beta blockers for their heart failure, adding verapamil decrease the risk of hospitalization for heart failure, and this is the other application of ivabradine. So ivabradine used in angina pectoris, in heart failure. In angina, we're reducing the sinus rhythm, the SA node activity through blocking the IF channel, and this is clear for everybody now. We're reducing the frequency of firing from SA node. We're reducing the demand toward the oxygen, so we're reducing the angina symptoms, and it's a real good drug. Ivabradine really has a nice activity. Also, we have an application of ivabradine within the heart failure, because we want a heart failure to reduce the chronotropic activity without having an effect in inotropic activity, and put the context within the lecture we talked about yesterday in heart failure, and that's the ivabradine, let's say, by per se. Now, adverse effect, this is especially interesting in terms of adverse effect. It produces something toward the blurred vision, which is the last one here. However, blurred vision is not really common to happen. It's happen in 1 to 2% of patients. Around 1% of patients will have a blurred vision. However, we have another thing that really interesting and need to be taken in consideration, and need to be told to your patient that there is an 14.5% of patients taking ivabradine experience what we call it luminous phenomena. And what is the luminous phenomena? It's really something to do with the eye, in which that phenomena the patient describe as a sensation of enhanced brightness in a fully maintained visual fields, meaning the eye of your patient or the vision of your patient will change and will have more brightness. Okay, and that really has to do with the transporters, which would it's an IH ion in the retina, which is have an activity similar structure toward the IF channel, which is, we talked about sodium. Here we talk about potassium channel, which is IH ion channel, and that gonna be inhibited within the eye. So this is what we call tissue selective activity. So if you bind toward, as we said always, there is no absolute selectivity. If you bind to inhibit the IF, the currents and the SA node for the sodium, you're now producing another activity within the eye, and that comes from the activity toward the IH channel within the eye, and that produce a phenomenon. You need to understand this for me, luminous phenomena, and this is a very interesting. Now, Also, this is trademark. As we said, digoxin will have xanthopsia. Now here we have a luminous phenomena for ivabradine. Okay, in large clinical trial now, we talk about other side effects. Bradycardia occur in 2 to 5% if your patient having a high dose, let's say 7 to 10 milligram. Okay, while that in comparison with atenolol, you will have a beta blocker, a selective beta blocker, you will have that percentage by 4.3. So watch for the bradycardia if using a high dose of ivabradine. So some patient will be dosed 5 milligram, some of them will dose 10 milligram. So watch for that. And remember always about the heart failure, which dose you have to use. And here we will not talk much about this clinical application. In the fifth year in therapeutics, you will be told about this or learned about this. Generally speaking, there's a headache issue again and again. Remember, this headache is a problem with the nitrates, it is a problem with calcium channel blockers, and now again the headache will be a part of the story, producing 2 to 5% for patients has been reported headache in a trial that be done around 2010, I believe. That's all about ivabradine. Simply speaking, ivabradine is a IF inhibitor that reduce the SA node firing, producing less oxygen demand toward the heart, and also producing an activity within the retina. However, not for the IF, it's for the IH, and they're producing a phenomenon called luminous phenomenon, 14.5%. This is reversible stuff, and no problem, I think, with this. The patient will get rid to this, and this is a reversible issue. However, remember, there's a blurred vision may happen to your patient, headache for 5%, up to 5%, 2 to 5%, and the bradycardia, something to watch for also when you use a 10 milligram of this drug, and this is the ivabradine. Now, another very interesting drug that really in use now, another anti-anginal drug that has a nice activity, ranolazine. And ranolazine, okay, this is another drug. It selectively inhibits the late sodium influx in the myocardium. So in the myocardium, there is a late sodium influx, and that interesting to have the tension within the diastolic time. So that's really happening when your patient have an angina. You will have more tension toward the wall tension, vessel tension, stiffness for the wall and the heart. So that will, if the sodium get in within the late stage, meaning the diastolic stage, that will produce the calcium more in, and you will have an overload of calcium. And that is a special trademark, if you like, for the ischemic abnormality for ventricular repolarization, and that will result in reduction of contractibility and the efficiency of the contractibility, and will have more oxygen demand on the heart. And whenever we talk about oxygen demand, you have to remember we're talking about the angina. So ranolazine has an activity within angina because it selectively inhibits the late sodium influx in the myocardium, reducing the calcium overload, attenuating the ischemic abnormalities of ventricular repolarization, and resulting in reduced contractibility. It improves exercise tolerance while reducing the frequency of angina episodes. Very interesting, and this is the application because it reduces the demand toward oxygen, it produces better contractibility, and it has reduced the diastolic tension within the heart of the patient. Now we have no effect on the heart rate or the blood pressure, so we improve the angina pectoris. Where we want to have ranolazine activity. Okay, so let's talk about ranolazine again. Ranolazine again, it's a inhibitor for sodium channel, and that sodium channel that open it, we call it a late entrance for that sodium, and that the late entrance for the sodium will happen within the ischemic ischemic cardiomyopathy situation. We have too much sodium influx, and when we have too much sodium influx, we will have again sodium overload, and we will have, if we have sodium overload, that will bring again the calcium overload for the exchange between sodium and calcium. And I understand you understand this from the physiology and from the digoxin story. So we have what we call it diastolic relaxation failure and extravascular compression, and that was something that you don't want. Why you don't want? Because that gonna, I'm reading here in the corner, increase myocardial oxygen consumption, reduce myocardial blood flow, and oxygen supply for the coronary artery, even to supply toward the heart. That will have a problem, that will worsen the ischemic angina. So, simply speaking, Ranolazine has that activity of inhibiting that late influx of sodium. So if we inhibit late influx of sodium, we inhibit late influx of calcium, and reducing all this pathophysiological problem, which is sodium overload, calcium overload, stiffness of the heart, and reducing the myocardic, reducing the myocardium oxygen supply. We reverse all that with a very interesting and important drug called Ranolazine. So Ranolazine is the drug that has activity against late stage sodium influx, and we talking in reality now about the diastolic pressure and diastolic perfusion time and so forth, so on. However, we don't have an activity against let's say contractibility of the heart. We don't have an activity reducing the contractility, nor we have anything to do with the heart rate. Okay, so that's the renal. Okay, let's talk about this. Is more more clear here. If you have developed an ischemia, your oxygen demand will increase, heart rate will increase, blood pressure and preload and so forth, so on. All that gonna increase, and we reduce, and that gonna reduce oxygen supply. We traditionally deal with this with the beta blocker, nitrates, calcium channel blockers, the traditional anti-anginal drugs. However, this is a new anti-anginal drug which work on the consequences of such ischemic issue. So the consequences of issue, that meaning too much sodium in the late stage, too much calcium overload in late stage, electrical instability, myocardic dysfunction, and systolic function, reduction in systolic function, and increase diastolic stiffness. And that's something you don't want to have. So Ranolazine will stop this and have a nice activity against the myocardic ischemic disease, especially within the angina pectoris. So very interesting drug, nothing to do with the heart rate. It's improved the contractibility. However, it's not have a positive inotropic activity. It's just reducing the oxygen, demand, producing better perfusion toward the coronary artery, toward the heart, and so forth, so on, reducing the stiffness of the heart. And this is the Ranolazine. Okay, Ranolazine. Okay, very important. And this is a very quick story. Beta blocker will reduce all the heart rate, and the impact on the heart rate and blood pressure will be clear. That they're gonna decrease pump function. That's the physiological mechanism, and that's something you want, as we said, and that gonna be reversed by the vasodilator like nitrates, especially in the impact on the blood pressure and so forth. So we combine beta blocker with nitrate. We talk about this, and calcium channel blockers will have an impact with it, which is the negative impact in the chronotropic and inotropic activity. However, Ranolazine has no effect on chronotropic nor inotropic activity. It reduces the cardiac stiffness only. Okay, producing more perfusion toward the heart, producing better diastolic time, less diastolic stiffness, and so forth, so on. This is a very important Ranolazine. Okay, now you understand that we doing something with the currents now. We have a prolongation for Q2. So there's a slightly increase in Q2 interval in some in some patient, and the FDA label contain a warning for this. So we have a QT elongation, and you have to watch for all these drugs that are producing QT, and we will come to that in when we talk about the anti-arrhythmic drugs now. But we need to know that there's a warning about Ranolazine that QT may prolong. However, the prolongation is not much, and that comes from the effect on the potassium currents for the potassium channel here. So I'm gonna read the QT prolongation effect of ranolazine on the surface electrocardiomyogram is the result of inhibition of the currents for potassium currents, potassium current, which prolong the ventricular action potential, and that's gonna be a prolongation for action potential. So drug the effect on Q2 intervals increased on the setting of liver dysfunction. So that's, we talk about the contraindication now. Ranolazine is contraindicated in patients with severe liver disease because they're gonna increase the level of ranolazine. And the Q2 interval prolongation, which is we don't really, it's not a big matter for us, really speaking, because there's slightly increase. Now it's becoming a problem because there's a problem in metabolism of ranolazine when we talk about the patient with liver ranolazine, and that ranolazine will have an activity toward what we consider as what we consider as inhibitor also for the beta oxidation from acetyl CoA to the acetyl CoA reduction story, which is in red here. So trimetazidine have an effect, an inhibitory effect here in CBT1, which is a part of the free fatty acid utilization toward the oxidation. Okay. However, it also will have an activity of beta oxidation, and that's a real activity of trimetazidine. So let's do it again. Trimetazidine is a drug that purely have an activity of switching the oxidation, switching ATP production, or ATP production, yes, energy production from the fatty acid toward glucose here on the right hand side. So trimetazidine is a switcher of oxidation, or let's say of energy production. So generally speaking, in ischemic disease where we have a less oxygen, the heart will build their production for ATP on the fatty acids. So we'll have mostly 80% or more utilization for fatty acid to produce activity, and we need this ATP to produce the contractibility and so forth. So on, remember we're talking about angina. So glucose will have less demand for oxygen. So if we're switching from fatty acids toward the utilization toward the glucose utilization, we'll have a reduction in oxygen demand, and that's the trimetazidine. So that type of a drug is a metabolic drug. Okay, it has a nice activity toward metabolism, and it's a part of improving the performance of the athletes. So it's been listed within the doping, meaning الأدوية الممنوعة في الرياضيين، أنا بتحسن activity of the heart and produce better activity. And there's a lot of talks about this, whether it's really need to be banned toward the athletes or not. However, just to link things together now, trimetazidine is a switcher from fatty acid utilization toward the glucose utilization, and gonna produce less activity. Now, what's the story of the previous talk we talked about? Ranolazine also have some of this activity. However, ranolazine is more to do with the late influx of sodium and late overload of calcium, and has some activity toward the metabolic condition. So trimetazidine, it's a drug that stimulate glucose consumption by myocardium with no activity against hemodynamic activity, meaning that not produce anything to do with the chronotropic, inotropic, or blood pressure, or anything, nothing to do. However, there's a special type of interaction which is to do with the brain. So it has an activity toward Parkinson symptoms, may cause Parkinson symptoms, is in very rare cases. However, if your patient have a Parkinson here, it's really contraindicated because it's worsen his Parkinson. It's also produce another type of side effects to do with the brain. We call it extrapyramidal side effects, and we'll talk about it in a minute. But if we're talking about metabolic modulation, which is PFOX, trimetazidine is the one that inhibit beta oxidation here and switch toward the glucose, toward pyruvate, rather than fatty acid, free fatty acid toward acetyl CoA, and so forth, so on. So that is the energy production. So O2 requirement for glucose pathway is lower than the free fatty acid pathway during ischemic oxidation. Oxidized fatty levels rise, blunting the glucose metabolism, and we want to block this with the trimetazidine. That's what we want. So simply there's a switch toward fatty acids because there's an hypoxia, and the hypoxia produce a reduction, more activity toward free fatty acids. So we stop this and we switch toward glucose, and this is the trimetazidine. It's very interesting. Okay, now the side effects is Parkinsonism, as we said, may produce more to some sort of Parkinsonism. Little in patients. However, if your patient is Parkinson patient, is contraindication to use trimetazidine. However, remember another rare side effects which is happen within less than 1%. It's symptoms we call it extrapyramidal. بالعربي ال الأعراض الجانبية الفوق هرمية. هذا بنتكلم عنه يا جماعة. We'll talk about it in the CNS system. It's something to do with the brain and linked toward the motor movement, and that will be really clear when we talk about that in the CNS. It's extrapyramidal side effect. There's many drugs that producing extrapyramidal side effects, and those drugs to do with the schizophrenic drug or antipsychotic drugs. However, trimetazidine is the one of the drugs that really produce this type. However, in rare cases, and you have this interesting story. Just to make you remember the story, it has restless leg syndrome. يعني المريض بيضله ماسك اجره او عماله رجله بترج. لو اني انا بالمحاضره فرجيكم كيف، بس هي هاي القدم الرجاجه. اوكي، احفظوا تراميزيدين producing extrapyramidal side effects of القدم الرجاجه. فسيمبلي speaking, just to remind you with this, it's Parkinsonism, extrapyramidal side effects like tremor, rigidity, akinesia, and hypertonia. And I don't have to tell you about all this. Just to remember, there's a restlessness in the patient, meaning tremor and restlessness syndrome. Not to prescribe to patient with Parkinson disease, Parkinson symptoms, and tremor, restless leg syndrome, and so forth, so on. And this is the third drug for angina. Remember, we're treating angina now, and there's many talks about many issues about trimetazidine. Just you need to understand what I said about this drug, and in future things are changing a bit. So watch for the changing for the trimetazidine, because there's a clinical trials talking about the efficacy of these drugs in the angina pectoris and so forth, so on. There's a bit of lack of efficacy, بس انتم ما لكم علاقة بالموضوع الآن. بس you need to understand there's a drug called trimetazidine that switching fatty acid toward utilization, toward cause utilization. That's what we want to understand. If the label change, I will tell you, or you have to watch for the label change for trimetazidine. في تطورات هذا الدواء شوية، في مشاكل على الاكتيفيتي تبعته، بس generally speaking لساته موجود as anti-anginal. Okay, last drug we talk about is Nicorandil. And Nicorandil is a nitrate. Because it has del, you understand there's nitrate, something to do with isodil, something like we know about the trade names. However, this drug has a special matter. It has two parts, and part that would work as a nitrate, and another part will work on the potassium level. So let me read about the side effect, the mechanism of action, and we will talk about it in a very short way, because this drug is just another drug that used for treatment of angina. It has other applications, however, just you need to understand its mechanism of action, generally speaking. Now, it increases cyclic guanosine monophosphate and facilitates the opening of mitochondrial potassium adenosine triphosphate channel. So, generally speaking, it opens the potassium channel. Now, this drug is a second line option to treat patients with stable angina when they do not tolerate or cannot use beta blocker, meaning calcium channel or calcium channel blocker such as Ivabradine, diltiazem, or when they do not respond enough to first-line therapy. So the usage of this drug is limited. However, it produces a side effect toward the gastrointestinal tract, skin, and mucosal ulceration, especially if used with the acetyl salicylic acid, non-steroidal anti-inflammatory drugs. Okay, in this case, the drug should be discontinued permanently. Okay, so if it produces gastrointestinal and skin mucosal ulceration, meaning the drug is has a special side effects in a special type of population, and this is the Nicorandil. Okay, remember this. Now, the interesting part of this, the Nicorandil has two parts. It has a nitrate part, so that a nitrate association effect, which is seen here, vasodilation of coronary epicardial artery, and it has a potassium opening activity. Okay, so that will produce ischemic preconditioning, dilation of coronary resistant arterioles. So that's what you want to know about this drug. So it's nitrate like drug with a positive potassium